Hi, my name is Ashish Patel. I'll be talking about trans-abdominal motor action potential, or TMAP, and how I use that for my lateral lumbar interbody fusion cases. TMAP functions much like transcranial MEPs. However, the electrode is placed over the conus medullaris, and a current is sent that propagates to the lumbar plexus, eliciting a motor response. The voltage required to cause contraction is monitored and compared to baseline value for real-time evaluation of nerve integrity. TMAP allows you to select 5 channels or myotomes to monitor, and for an L4-5 prone lateral, I'm most concerned about femoral nerve health. And so I select vastus lateralis, vastus medialis, adductor magnus, and tibialis anterior for broad coverage of femoral nerve health. This is the layout for TMAP on the screen, and you can see that there's numbers and there's waveforms. However, the numbers make TMAP very user-friendly. Each myotome is individually labeled, and you can directly see the current change from baseline. When possible, I try to keep the max stim at 1500 milliamps so I can observe the full change. TMAP is color-coded. Green means that any change is less than 150 milliamps. Yellow is a change greater than 150 milliamps. And red means there's a loss of signal with no contraction in the myotome. Current industry alert criteria is any change greater than 150, and we are working on a multi-center study to examine this threshold. During lateral surgery, especially L4-5, an injury can occur from the time the dilator is placed to the time the implant is placed. So I wanted to ask myself, when do injuries occur? So I began running TMAP systematically throughout my cases. Because TMAP gives us real-time data, for every case, I follow this protocol, and it has allowed us to identify when nerve injuries happen intraoperatively. Through our single-center effort, we've learned TMAP alert criteria with a threshold change greater than 400 from baseline shows 100% sensitivity and 86% specificity for predicting a post-operative quadriceps neuropraxia. This is an example of my current operative algorithm or workflow. When there's a change of less than 400, I keep going, and it is very unlikely that the change correlates to a clinical issue post-operatively. If the change in TMAP becomes red and there's a loss of signal, I close the retractor and rerun TMAP after a minute. If there's improvement, I may move forward depending on the clinical scenario. If it remains red, then I audible to a TLIF or posterior-based approach, and I abort the lateral. If I have a change of greater than 400, I examine where I am in the case, and if I'm putting in the cage, I finish swiftly and carefully. If I am not close to finishing and this change is occurring early or is a progressive change, then I follow the red algorithm and I abort to a posterior-based surgery. The rest of this video is an example of how I use TMAP in a case. First, we get our baseline values to use as a reference point for the rest of the case. Come on, flat. TMAP. Okay, TMAP. Shot. Save that.
Less than 400.
All right, what is it?
Left is was 400, or is 400 plus 250.
All right, let's come up over. Save that left. All right, save that left to right. Come up to an AP and then mag it this time. Run a TMAP.
Okay, running TMAP. Okay.
Let's see the other dilator.
Change less than 400.
All right. What is the change? Same thing?
Same as the last run.
All right.
Perfect.
X-ray. Again.
Angle looks great.
Run a TMAP.
Okay, running TMAP. And baseline.
Thank you. Grab the string. Oh, put the extra small. I'll grab the string. Run a TMAP.
Okay, TMAP.
X-ray. Now.
And baseline.
Run a TMAP again, please.
TMAP. And baseline.
Run a TMAP.
Okay, Change less than 400. Same as last run.
Whatever you got. TMAP, please.
Change less than 400.
Zero, please. Lights up. TMAP.
What a level?
Yeah.
Okay.
Whatever it was before.
Change less than 400. Same as last run.
Thank you for your attention. I hope this video demonstrates the value of TMAP and how I incorporate this into my practice, in which I can get real-time data and an understanding of nerve integrity during the approach.